Hi, ladies and gentlemen. This is Congressman Jay Inslee. Thanks for joining us this evening. We're very appreciative of your assistance tonight to help us talk about our healthcare situation in this country, and obviously this is of great importance. And we're very excited about the opportunity to talk with you tonight. What we hope we can do is this evening, I would like to give you a summary of some of the issues that are going on in the national discussion back in the nation's capital. I obviously have been engaged in those. I serve on the Energy and Commerce Committee that has one of the principal jurisdictions in the House, so I've been very active in this discussion. And that's what we are involved in right now, is a national discussion to see if there are things we can do to improve our healthcare delivery system and our insurance system in the United States. And we are very much in a discussion mode. Nothing has been decided in Washington, D.C., so your participation tonight is very timely in helping us fashion this proposal. So what I'd like to do, I'm going to give a few moments discussion of what is pending and what ideas have been discussed in Washington, D.C., and then we will take your questions and ideas and suggestions, and if you punch *3 on your phone, you'll get a person in our office, and they'll set you up eventually so that we can plug you in and ask a question or make a comment. So let me start by giving you sort of a basic idea of some of the issues that are under discussion in Washington, D.C., and I'll start by sort of identifying the things that I think many of our neighbors do have concerns about in our current healthcare delivery system, which in many cases, of course, is excellent. We have incredibly skilled physicians, incredibly competent, particularly in our area hospitals. We have a lot of success, and I know many of us have had family members who've had fantastic healthcare services in our country, so I don't think that's something we should forget. That being said, it is clear that there are some things that are less than perfect in our healthcare system. And let me just start by talking about some of the things in the insurance world that people are talking about finding a solution to. First, there is a concern amongst many of our neighbors who have insurance now, who may be very happy with their insurance, but always face the risk of becoming uninsurable. And we know that in the current world, in the insurance world, that if any of us, even though we are healthy today, if we develop cancer or diabetes or emphysema, or if our sisters or brothers or sons and daughters do so, they become essentially uninsurable because they can be excluded from insurance because they have a pre-existing condition. And this pre-existing exclusion essentially makes many of our compatriots, and perhaps us, if we develop a condition like this, either uninsurable or have to pay extremely high premiums in order to obtain insurance. So the first order of business that is being discussed is a way to change that so that we are not subject to the whims of becoming ill and then becoming uninsurable. And the proposal that's now pending in the House that has been proposed by the President would eliminate that potential problem for Americans and get rid of, for all time, the pre-existing exclusion condition problem. The second thing that people have talked about is the issue that people are sort of sometimes stuck in their jobs because they have a condition like that and cannot change the their job status because they can't get insurance that they have to change. So if we do eliminate the pre-existing condition, it will free people to change their jobs, and they'll no longer be enslaved to that situation. Third, we have a problem of lack of choices in some circumstances, that there may not be adequate choices for insurance, and there are discussions of a variety of ways to give people more choices. And one of the fundamental tenets of the proposal that is now pending that has passed the Commerce Committee I serve on is choice, to assure people that they have a choice of where they obtain their health care coverage. And I can report to you that that principle is being maintained in the policies that are now being considered, at least in the House of Representatives I serve in that all Americans would retain their right of choice, so that if people wanted to maintain their choice of their existing insurance carrier, they would be entitled to do so. If they wanted to change, they would be entitled to do so. Only their choice would be increased, because now they would be able to switch insurance policies even if they did have some condition. And third, there is the proposal of giving Americans a choice to have access through a Medicare-like situation, what people are calling the public option, so that they'd be able to obtain their health care like veterans do now and like do people on Medicare through a public plan. The next thing that we know people have concerns about is potential bankruptcy, even though people do have insurance. We know that people can have catastrophic situations that just can overwhelm them financially, even with insurance. And there is a proposal now, the President has proposed, that would essentially put some limits on the exposure of individuals, particularly for wellness and the like. We know we want to encourage people to stay physically fit and obtain preventative health care, and the bills that are now being considered would essentially prevent insurance companies from forcing Americans from paying a copay for preventative health care, because obviously we want to encourage preventative health care. The bills that are being proposed in the House of Representatives basically assure that the significant parts of the cost of this system would not be borne on middle-class people. The proposal now pending in the House would essentially finance this plan with an increase in of the tax rate, going back to the tax rate for people over $350,000, single people who earn over $350,000 a year, and companies of over $500,000 would need to provide health insurance or make a contribution of a certain percentage to the cost of essentially this program. The last thing I'll note is that we have about 45 million Americans of our neighbors who do not have insurance. And we know that this is a problem not just for them, but for we who are fortunate enough to have insurance. Because unfortunately we are all paying a hidden tax right now. The hidden tax is that all of us who have insurance now pay about $1,200–1,300 a year of our premiums that go to the increased costs that our insurance companies have of paying the uncompensated care of people who do not have insurance. People who don't have insurance go to the hospital, rack up big bills they cannot pay because they have no insurance. Those hospitals then need to charge someone for that uncompensated care, and they charge our insurance companies that then have to increase our premiums, on average about $1,200 or $1,300 a year. So the fact that we have 45 million Americans who are not insured is a problem for all of us, not just those families. And this bill, by increasing coverage to about 97% of Americans, would help alleviate that problem by reducing this uncompensated care. Now, obviously, it would have the benefit of families, these 40 to 45 million, who, by the way, most of whom are working. These are not people just goofing off down at the park. And most of them are working Americans who have not been able to afford insurance yet. And those Americans of low income would receive a subsidy under the plan to help them pay their insurance premiums on a sliding scale basis up to about $80,000 per family, $88,000 per family, so that none of them would have to pay over 12% of their incomes towards insurance. So it would be both a message of personal responsibility that everyone would have some obligation for their own care, but also assist some of the lower paid Americans with assistance to provide and buy their coverage. One last thing I'll note before we turn this open for questions, there has been much discussion about the ability or wisdom of providing people a public option, the ability to obtain coverage through a Medicare-like system, or the kind of system that we receive health care from as members of Congress. That is in the bill that is moving through the House of Representatives. It's something that I frankly think is a worthwhile idea, because it does hold the feet to the fire of the insurance industry, and does provide coverage and a choice for people should they want to exercise that choice. But it is only a choice, and people are certainly not obligated to go that route. So that is a very quick description of the bills that are now, or the issues that are now pending. Just a momentary discussion of where the process is. We passed a House, in the House of Representatives, the three committees that have jurisdiction over this have all passed portions of the bill that will be joined together in September into a bill that would go to the House for a vote, and there may be amendments at that time. But the skeletal structure of the bill has been at least formed in its general sense, and the general sense is the bill that I've been describing to you. In the Senate, two of the three committees have worked their will. The third has not. What will be proposed in the Senate is much more ill-described at the moment. We don't really know exactly what the revenue source will be for this. There are larger gaps, frankly, in the Senate discussion. And of course, whatever bill comes out in the House and Senate would then be reconciled. So there's a lot of work to be done on this. There are many questions to be answered. This is an extremely complex bill, and I'm very appreciative of your ideas and suggestions on how to move forward in this regard, because we know how important this is to our families. So with that, I would like to turn to our citizens for questions and ideas, and we're going to start this evening with Judy from Woodinville, who had a question about private coverage. Judy, would you like to take the first shot here?
Yes, I would. Thank you. Okay, my question would be Section 102, protecting the choice to keep current coverage. In this section, does it make it illegal to keep my private insurance if I retire or change my job?
No, it totally allows you to exercise whatever private choice that you seek to exercise. And again, as I noted in my comments, I think it's very important in this that we preserve Americans' right of choice. Americans do not want to have some process that they haven't bought into or feel comfortable with. And this President Obama has proposed a system that would guarantee people's right of maintaining their insurance. Now, that's of course only if you have a policy that allows that. If you have an employer-based system right now, for instance, if you are insured through your employer, but that insurance only lasts during your employment, you can exercise COBRA rights to maintain that, but that only lasts for a certain period of time. So you still would need to have potentially insurance if your employment lapsed. The good news about this proposal, if that happened, let's say you were laid off tomorrow in the recession, you would have two great advantages, actually three great advantages under this bill. Number one, if you have some condition that would otherwise make you uninsurable or allow an insurance company to charge you a large premium because of your condition, they would no longer be able to exclude you if you wanted to sign up for an insurance policy that you privately paid, nor would they be able to pay you, force you to pay an exorbitant premium because you have a condition. So it would be very, very beneficial to you in giving you that security. Number two, if you if you earn less than $88,000 a year as a family, you would have a subsidy from the federal government that would assure that you never pay more than 12% of your net income towards health insurance. That's, of course, a sliding scale depending upon your income level. So there are some benefits to those of us who have insurance in the light that we do lose it, but it would remain your choice, and I think that's an important part of the bill. Thank you very much. We have Barbara from Linwood, a question about paying for the bill.
Yes, I was wondering, Congressman Inslee, thank you for doing this for all of us.
Thanks for
how does the government plan on paying for this? I don't see that we have the money. I've done the math. I don't see where this money is coming from. That's my concern.
Well, it's a very important concern because we do not want to, bend us to the deficits that have been so onerous and of concern in the recent past. We know that the deficit has gone up. There's been some spending as a result of the recession that's increased the deficit. I know that's worrisome and troublesome to you and me and a lot of people on the call tonight. So we're seeking ways to make sure that we don't go backwards fiscally in this regard. And the bill has improved in a couple ways that I'll describe to you since it was originally introduced. I know there was a lot of concern. I had a lot of concern, frankly, about the way the bill was originally introduced that I didn't think was satisfactory on really paying for it. And so there are two ways that essentially the bill would be paid for. Number one, there are measures now that frankly were not in the bill when the bill was originally introduced, which would help constrain costs. And one of the ways to pay for it is to reduce the rate of medical inflation. Now, this is very troublesome because the medical inflation rate is today about 7 or 8% a year, but our wages are only growing at 2 to 3% a year. Our economy is only growing at 2 to 3% a year. So the medical inflation rate is really eating us alive, and to pay for this bill, we have to find a way to, you heard this term before, bend the cost curve down, in other words, reduce this rate that the medical inflation rate is going up. So one of the ways it would pay for it by taking some action, a number of actions that would help us receive quality care but reduce the rate of medical inflation. And those are principally designed to do things around the country that we are already doing here in Western Washington. We're doing some really good things. Our doctors and hospitals are doing some really good things here to try to reduce medical inflation and still provide us quality care. One of the things they do is they practice in groups so that physicians share information amongst themselves. And when they do that, we find that that can be very beneficial in preventing unnecessary surgeries, unnecessary x-rays that really don't help our quality of care. And as a result of those things, we've been very successful here. We spend about $7,000 a year on Medicare patients in Seattle, and we spend $16,300 at a patient in Miami. I mean, it's over twice as much because they're not doing some of these things. So the bill takes some actions that, and I've been very active in this, frankly, in adding some things to the bill that will change our Medicare reimbursement system to incentivize physicians and hospitals to adopt some of the measures we've used in Washington State. I was actually led a conversation this morning with leaders from Group Health and the Everett Clinic in Providence that have done some of this work. So that's the first thing. The second thing would be a surcharge on very high-income folks who earn over $350,000 a year, which would be about a 2% increase in the tax rate they now have, which would take it back to the rates that existed back in 2000. And that would be contributing a significant part. The third part would be there would be some contribution by employers who are today not providing for the insurance of their employees. Companies that have a payroll of over $500,000 would have some obligation to either provide insurance for their employees or contribute a bit to Uncle Sam to help pay so Uncle Sam can pay the subsidy to those employees to help them get insurance. That's a sliding scale. It goes from 2 to 8% a year. So those are the three ways. I still think there's more work to be done on the bill, and I think there will be more work done on the bill on this basis. We made significant improvements to it in the Commerce Committee, and it's frankly because I've been very insistent. I sort of led a group of 5 members in the Commerce Committee who insisted on some of these changes, and we were successful in negotiating a major change to the bill that would essentially create a program that 2 years from now these changes would have to go into effect to save costs unless Congress disapproved them. So it was a major improvement of the bill, and I hope there will be continued improvements along those lines. Thank you. We now have Rich from Everett as a question. Rich. I hope we have Rich here. And maybe Rich went on to another pursuit. There's a soccer game. Rich, are you there? I'm sorry, we're having a little glitch here finding Rich. or another person here?
I'm here. This is Rich.
Okay, Rich, go ahead.
Congressman, I appreciate your having this forum. I have a question for you. I'd like to know if we're concerned about the cost. Most of the physicians around the country practice defensive medicine to protect themselves in the event of a lawsuit. How come tort reform is not a part of this bill?
Well, that's a really important question. I'm glad you asked it because we do want to investigate any opportunity to practice better medicine. We do know that that goes on, unfortunately. Now, it's not right that it goes on. Physicians should not be ordering, exposing us to x-rays that are not medically necessary. And when they do that, that's not helpful to us. But the reason that there is not significant changes in tort reform, with one exception I'll discuss, is that we have found that it simply has not worked. It'd be nice to think that it would work, but it simply hasn't. And I'll give you the best thing you might want to read about it is there's an article in the New Yorker about 2 or 3 months ago that looked at these issues about how we restrain cost containment. And what they found is that states that had enacted changes to their civil judicial system and that had taken away decisions from jurors, for instance, had not succeeded in reducing the rate of medical inflation. The example they cite, it's sort of the poster child for this issue, is McAllen, Texas. McAllen, Texas is a not too large town in Texas. Texas has the most rigorous restrictions on claims against physicians, and they are really quite onerous and very restrictive. And yet Texas, and McAllen, Texas, has the highest Medicare payment rates of $16,500 in the nation. And the same can be said with California, where in Los Angeles they spend almost twice as much as we do in Seattle, and yet they've had the most restrictive changes in tort reform. So it simply has not worked, and one of the reasons those who have studied it have concluded is that the incentive system that we now have in payment seems to be that essentially gives people physicians for doing more unnecessary work is what really overwhelms this system. Now, the one thing that I do think that these changes would help physicians is that it would help create some protocols that they can follow. One of the problems physicians now have is that they are sort of at risk if a plaintiff can find a doctor anywhere in the country who will say that they thought the medical standard of care was violated. If we can develop some protocols that physicians can feel comfortable following, that they themselves adopt, and that's, by the way, one of the thrusts of this bill is to try to give physicians the ability to work with themselves to develop their own protocols, that they have a safe harbor. They can essentially tell the jury, look, I followed what the protocol was. It's been adopted by the physicians in my area. We've all embraced it, and that can serve as a defense. And this bill does that. In fact, I was successful in putting an amendment in the bill that would require 10% 10% of the funds for Medicare would go to accountable care organizations, where physicians work together to define these protocols and review each other's conduct, frankly, and professional actions. And where we've done that, like we've done it at Everett Clinic and Group Health and otherwise, it's been very successful in both reducing losses due to negligence and saving us taxpayers a lot of money. So I think these things will be helpful in some regard. Next question from Marianne Edmonds had a question. Marianne in Edmonds?
Yes, thank you so much for this opportunity.
Yeah.
I have so many strong feelings about this because I'm retired, and I was a healthcare worker, as well as I was a spouse taking care of a very ill husband. So I know a lot about healthcare. But what I can't understand is why there is such a rush about all this, because there is so much that we can improve about what we have. No one is going without health care. We know that. And the media, the whole 9 yards, is telling us that we don't have health care. I mean, it sounds like we don't have health care, but people are not dying in the streets. We just have people that are uninsured, and they are being taken care of, though. And that is the frustrating thing to me, is that I know that people are being cared for. So, and with the best of care. I was a social worker. I helped with eligibility for Medicaid and for Medicare and the whole 9 yards, and dealt with street people as well as very wealthy people. And I just don't understand why we're in such a hurry.
Well, let me tackle. There's a couple questions in there. First, about the pace of consideration of this. We are not going to act until people understand fully what's in these bills, and we have a chance for all of us to consider this. It is a big decision for all of us. We originally had thought that we would have the bill under consideration before we broke for this district work period. But we frankly had more questions, and we slowed down the process, and members have wanted to have a chance to talk to their constituents like we're doing tonight, to listen to people and really consider the implications of the bill. I think that we will have a chance to improve the bill when we get back in September. So I think we are listening to the need of people to take a bit more time to consider this, and I think the bill will improve. I'll just tell you, I think a realistic timeline is by the end of this year to consider this issue, whether we will or will not accept the status quo. And by the way, I think that the issue before the nation fundamentally boils down to this: is the status quo good enough for America, or can we do better? And that is the fundamental question. Now, my perception is I do believe America can do better in her health care, and you bring up a point about the 45 million Americans that have insurance, and your position is, and your view is that they are receiving adequate health care today, the same health care that I receive in Congress, who has a decent health care plan. I very much disagree with your statement, and I have to tell you why I disagree with it. And for two reasons. One, as you correctly pointed out, many of those people get access to emergency services through the emergency room. When they get very sick, when they get in the late stages of emphysema or diabetes, they will go into the emergency room and receive emergency care. There are two reasons why that is not adequate. Reason number one is it costs us enormous amounts of money. When one of those people goes into emergency, it costs probably 5 times more, and the people who are paying for that is you and me and everybody on this call who has insurance. Because when those people go into the emergency room, you and I pay 5 times as much as it would cost to provide them coverage had they had a private insurance plan. So even if they do receive it, even though they do receive it, it's in a very cost-ineffective way, and you and I are the ones who end up paying for it. The second thing is that for the health of these people, and by the way, these are not bums sitting down on the street drinking wine out of a brown bag. These are our kids who are getting their first jobs that don't have insurance. They're students that are now over 18 age, and we can't cover them on our own policies. They're people who have pre-existing conditions, who may have, been good, tax-paying, hard-working people, and they get sick. I mean, I have a friend 3 weeks ago. He's a firefighter, and his kidney stopped working. And turns out he has cancer, and he's no longer going to be insurable, and if he had to change jobs, there's no way he could get medical coverage now if something didn't change in the policy. So the point I'm making is that the image of the uninsured here, sometimes people are just sort of ne'er-do-wells sitting on the sidewalk, and I just don't, that's not my picture. And the problem is when those people don't have insurance, even though they might be able to get it through the ER room, they don't get it in a timely fashion, and when they don't, they get sicker. and they get to us in the last stages of these diseases, and we might have been able to help them, particularly in chronic diseases like emphysema and diabetes and cancer. They don't get in for wellness checks. They don't take care of, they might have, a spot on their skin. They don't go in. It turns out it's melanoma. And I don't think that's acceptable. I'll tell you one short story about this. When I was first in office, or actually running for office as a state legislator, I was standing on the corner holding my sign, and this lady walked up the sidewalk to me, and I said hello, and she had her head was all bandaged in bandages. And I just said hello, and I said, how's your head? And she said, well, I have a lot of pain. And I said, what happened? And she said, well, I had a tumor, it had to be removed. And I said, well, why don't you go back to your doctor and, get some pain medication? And she says, well, I don't have a doctor. And I said, well, why don't you go back to talk to the doctor who did the surgery? And she said, I didn't have a doctor. I cut that off with a paring knife in my kitchen because no one else will do it. And they don't do that kind of stuff in emergency rooms even. And she said she didn't have insurance, and she had a new baby, and she had to do it herself. And, I don't think that's good enough for the country, at least in my view, and it's very expensive to us as well. So anyway, that's the reason to move in a judicially considered way. And I have to say, we are looking at this, every line of this bill. I have spent many, many hours doing that and have been in very intense discussions with my colleagues about it. Our next question is from Chris in Bothell. Chris, you have a question?
I do. Thank you for taking my question.
Thank you.
I wanted to find out, okay, my history is I was 2 years ago diagnosed with breast cancer after having complete well checks, all that kind of stuff. Mm-hmm. We were insured through our company, but they never covered, for instance, comfort drugs. So you just were talking about those pain meds that would have made somebody comfortable. Yeah, they didn't cover those. They would cover my chemo and my radiation, but not anything to treat the bad burns, because that would have been comfortable.
Right.
And my real question is, who evaluates what are necessary tests? Because you're holding group health up, and I have had, because I run in the cancer world now and basically am uninsurable, and plus I have diabetes too, so really uninsurable. I have met many people who were in group health, and yes, they control their costs, because by the time you do get in to see a doctor in group health, and by the time they really decide to order a test that could find out what's wrong with you, your cancer is advanced. And I've buried several friends who were insured at group health and were young. They shouldn't have died, because group health did not evaluate that they were necessary tests for a person their age. So who in this plan is going to evaluate necessary? Insurance companies don't do a good job of evaluating. Group health does a lousy job of evaluating. So who is going to, is it some bean counter out there in Nana land that evaluates who doesn't know the patient?
First off, I know everyone on the call is hope that you're doing as well as possible, and all of us are wishing through these telephone lines or sending good wishes to you, so I hope things are looking up for you. And we appreciate someone who has a personal story like this is willing to share it with us, so thanks a lot for being on the call. The answer is no. This bill would not create some sort of master bean counter sitting behind a computer screen in Washington, D.C. that's going to decide whether or not you receive health care or not. And it is not intended to create a situation like that at all. First off, and I want to reiterate this, and I've said this now several times, but it's very important, whatever insurance company you now have, whatever system you now have, you will be free, totally free to remain in it. So if you don't like group health, you would be free to leave it and go to a different insurance policy. Only you now will have more choices of where to go. So a person like you who is dissatisfied with group health and would like to change carriers will now have freedom. You have a get-out-of-jail card, if you will, that will allow you to go to another insurance policy, and they will be required to accept you as a client if you will pay the same premium as everybody else. And that means you and I, if we're the same age, if you and I decided to go to a Acme insurance company and we decided to lose group health, they would be required to take us, even though we both had cancer and diabetes, and they would be required to, they could not be allowed to charge us more for a premium. Now, those premiums can change a little bit based on age, but not on our disease classification. So you would be giving number one, no new bean counters to deal with your situation, and number two, additional freedom to choose a different carrier should you desire. Now, under the House bill that has passed out of committee, you would also have the right, if you decided to receive a plan like members of Congress had and like members who receive Medicare now receive, which is essentially Uncle Sam paying your providers for their coverage. And if you were more comfortable with that rather than a private insurance company, you would be essentially eligible to join something very similar to Medicare. And some people might want to do that. Many people would not. But you would be given that choice. Now, the question of who decides what medical care is critical to this, and I very much appreciate you bringing it up. Obviously, we want medical providers who are trained at great hospitals making the decision about our private medical care. That's what all of us want for ourselves and our loved ones. And this bill would, I think, appropriately help physicians make those decisions, because what it would do is, the one thing it would do is for physicians who are receiving reimbursement from Medicare, they would be encouraged by the reimbursement system to work in what are called accountable care organizations, which basically are groups of physicians who work together to develop protocols about how to treat people based on the latest medical evidence. And the decision makers would remain physicians. They would remain nurses. They would remain internists. They would remain with X-ray technologies. It's not going to change who makes the decisions, but it could change, and I hope will change, to encourage physicians to work together so that they share information amongst themselves. And where they have done that, quality has improved. By the way, one of the remarkable things about this, when I've been researching this, the highest cost areas in America are usually the lowest quality. The highest cost state in America is Louisiana. And guess who has the worst health care in the country is Louisiana, because physicians don't work together there. They're sort of lone cowboys, and they charge you and I exorbitant rates, and they do procedures that may not be medically necessary, and they get worse results. So it's really strange, but there's almost an inverse correlation between the cost that we're putting in and the quality that we get out. So I hope that answers your question. I hope things look up for you, and thanks so much for sharing your story with us. Next one, we have Kathy from Spokane. Kathy, you may be the longest caller from the 1st District tonight, so congratulations.
Well, thank you very much, and thank you for speaking tonight on this, because I'm a critical care nurse and certified nutrition support nurse, and I have been fighting ever since the 80s to get nutritional status as a basic vital sign in healthcare, and it's not. So when we talk about healthcare, we need to look at the beginning and the basics of healthcare. And and that is not in. Consequently, we are having all of the problems in chronic diseases that are just devastating, catastrophic healthcare costs. I did send you the 2009 Almanac on Chronic Disease Impact. In fact, Surgeon General Carmona has said that the biggest threat to America is not the terrorists. The biggest threat to our nation is the obesity issue. And the obesity is the biggest problem, and our research that we have paid, it is the root cause of many of these chronic diseases, according to the Almanac and according to CDC. The good news is that we already have, right at your fingertips, like the previous lady said, what's the rush? Why must we do everything at one time?
why don't we look at the problem that we have? And in my fight, I want to share, and what I'm speaking to is the barriers that we have confronted.
Could I ask you kind of wrap up on, we want to get to as many calls as we can
Yeah,
tonight, so could you
right.
make a
We
closing
have
comment?
national guidelines on identifying people at risk of all those diseases, the cancers, the heart, the stroke, and you're involved in the diabetes, and you know about all the pre-diabetics. And we have those national guidelines right there that we could get into healthcare practice. We have it for the children, the BMI for children. And the heart, lung, blood came out with those in 98, and they still aren't.
Gotcha. Let me take a crack at that.
Now,
Yeah, let me take a crack at your question. Listen, and Kathy, I'm going to cut you off just for a second because we had a lot of people on the line, thankfully. We got a lot of people with great questions. I want to get to as many as we can. First off, what you said is the need to deal with wellness to prevent the onset of diabetes is so correct. I couldn't agree with you more. And one of the things that are in the bill are substantial proposals to help people deal with their wellness rather than just their sickness. And we intend to change the Medicare reimbursement rate so that people can have their physicians reimbursed for really helping them stay well instead of just taking care of them when they're sick. There are quite a number of provisions that will change the reimbursement system so that your physician, if you have an issue with obesity, your physician, you'll have a primary care physician available to you to work with you to help improve your physical fitness, frankly, and talk to you about those issues and deal with wellness. And right now we don't do that because we don't reimburse physicians to do that. And we have an epidemic of obesity in our young people. By the way, I've got another little bill called the Fit Kids Bill, which would essentially assure that kids have some physical activity in school. We also call it the Leave No Child on Their Behind Act. We got to get on ahead of this curve of diabetes. So the bill does quite a number of things to help. I don't know specifically whether it requires a nutritional component that you've mentioned, and I will try to get an answer to you on that specifically after our call tonight. By the way, you just jogged my thought on another thing. There are a lot of people who are, who don't want to see any reform in this country, who think the status quo is good enough, and a lot of them are multi-million-dollar companies that, don't want to see any change. And there is a lot of misinformation about this bill. One of the largest pieces of fabricated information, people saying that somehow this bill is going to kill Granny. And it's really sort of preposterous what people are willing to say to try to scare people, and there's sort of a scare campaign going on about this effort right now. There is something in this bill, though, that I think makes sense, and that is that it would give Americans, if they choose, if they want to talk to their physician about their end-of-life care, about what type of end-of-life care they will have, in what circumstances they want to be subject to extraordinary, medical intervention, that physicians will be reimbursed for that. And I frankly can't see how anyone would disagree with that. If you or any of us on this phone call tonight want to talk to our doctor about that, to at least allow us to compensate physicians to give you that service, and yet people have sort of turned that into sort of a communist plot to reduce our population if anybody gets to Social Security. It's just absurd. But in any event, some of that information is out there. Next question. Dennis from Bothell had a question. Dennis, are you with us?
Yes.
From Bothell.
Yes.
Dennis, we're waiting for you here to get on.
I'm on.
Go ahead.
Can you hear me?
You bet. You're
Okay.
on.
Yeah, okay. First of all, I would like to say that I'm very strongly against this bill. And part of the reason is because, over the years, Congress has spent us into a national debt of over $37,000 for every man, woman, and child. Okay, that's an obscene amount of debt. And why do you think that the federal government should spend trillions of additional dollars on this so-called health care bill, which would, just like out-of-control Medicare, plunge us closer and closer to national bankruptcy? I don't understand that. That makes absolutely no sense to me. And I think government, instead of putting themselves into these situations, they need to figure out how to get out of these situations because you're bankrupting us.
Well, I appreciate your strong statement. Obviously, you feel strongly about this, and I appreciate that you care about this issue because it's something that I've been working on for some period of time to try to get a handle on our federal debt. But let me just suggest that the status quo is killing this nation, and the status quo is that the medical inflation is creating an enormous federal deficit if we do nothing. And that's because Medicare expenditures are going through the roof. They're twice as high as the rate of our improvement in our wages. So doing nothing is a precursor for disaster fiscally right now. The big driver of our federal deficit is healthcare costs because they are increasing at twice the rate of our national economic growth. That is totally unsustainable. So the status quo is a recipe for fiscal disaster today and is the major reason. There are many other reasons. The war in Iraq that is unfunded. There are many other things that are problems in our fiscal house. But I think the problem is that we're going to go bankrupt if we don't change something. So I don't think the status quo is an answer to our problems. But we obviously don't want to dig the hole deeper. So the question is, can we find a way to reduce the rate of medical costs? I think the current proposals have an opportunity to do so, and I'll just mention a couple things to you. First off, the bill is intended to be paid for. In other words, the money it will be spent, there will be an equal amount raised by Uncle Sam through the high income tax increase for people who earn over $350,000 and only those who earn over $350,000. That plus the contributions by some employers, larger employers who are not providing coverage for their people today, that plus the savings that we are going to have by changing the Medicare reimbursement system are meant to even out. And if they do even out, even though we will have additional costs, we will also have additional revenues. And if those neutral out, you will not be increasing the federal deficit. Now, I am not satisfied still with the bill myself that it goes far enough in this direction to constrain costs. And I'm continuing to push, and I'll just mention one thing. I was appointed by the Speaker to negotiate an agreement to work on cost containment. And I can report to you success. We adopted an agreement last week which will essentially require a change in reimbursement rates to reduce the massive overutilization that goes on and decrease costs. And the Congressional Budget Office has said that that has opportunities to significantly bend down the cost curve if we adopt it. And that was something that we added to the bill last week that frankly I think is a major league improvement to try to answer your very, very justifiable concern. So we'll see if we get far enough down the road to that balance that you insist on. We're moving in the right direction. I don't think we're there yet. And I can tell you I will continue to press for these containment measures so that we don't increase the federal deficit. I totally agree with you on the necessity in that regard. Next one, Stephen of Linwood has a question. Stephen of Linwood. Excuse us, sometimes it takes a moment to get people up. Is Stephen with us here?
Yes, this is Stephen.
Go ahead.
Can you hear me?
Yes,
I want to thank you for doing. Yes, I want to thank you for doing this. I think this is great. First of all, I'd like to say I have a background in health research, so I'm familiar with some of these issues. Mm-hmm. And I want to just compliment you, too, on your efforts to reduce costs and implement good regulation. I do have one question, though. A lot of times in life we make assumptions, mm-hmm. and I noticed in policy issues sometimes assumptions are made, and they're not thought through or challenged enough by the people who kind of implicitly are making them. And it seems like the president and the congressional leadership are making some assumptions, and I'd just like to hear your view on these assumptions that seem to be implicit in what's happening. First thing is, when I listen to the president or the congressional leadership, they imply that a government entity, if we have one, will not take over the whole industry, will not drive out private insurers. And I'm not sure if that assumption has been really kind of vetted. Mm-hmm. Another assumption that I've heard is that the 50 million figure, I frankly read an interesting letter to the editor in the Financial Times. I think it's a very respectable newspaper. And it was from an academic, I believe in America, a university professor. And he said that their 50 million figure of the uninsured is way too high because many people have certain programs they can go into but opt out, or they don't want to be insured, or they're illegally in this country. And he said the figure, I think if I remember right, was much less than 50 million. So that's another assumption I don't feel has been fully vetted out. And it'd be nice if the congressional leadership and the president would explain that and break it down.
Yeah, let
think,
me
okay, and I just want to add one other thing.
Yeah, go ahead.
Okay, can I just have one more assumption,
Sure,
too?
go ahead.
I don't know if this is a misquote because, frankly, there are aspects to the media, both right and left, that there's a lot of misinformation. And being in research, I've learned to kind of sift that out and discard it. But I believe that Speaker of the House Pelosi was quoted as saying profits are immoral or evil. And is that an assumption you adhere to? Because I have degrees in economics and finance, and it's not that profits are evil, it's how they're used that could be incorrect. I mean, if they're used to give bonuses in a way that's bizarre, that's certainly incorrect. But if profits are used for research or development, that's really a good thing, both for the stockholders and for the company.
Yeah.
So those three assumptions, I'm curious on your take on them.
Yeah, well, first off, starting with profits, look, I think profits are wonderful. I'd like to have some myself someday, and that's probably not going to happen when I'm in Congress. But I think profits can be very beneficial to the American economy. They're absolutely fundamental to the American economy and to healthcare, frankly. I mean, what drives the development of incredible new drugs, many of which are being developed right here in Puget Sound, is a profit motive. And that's what drives people's willingness to take huge risks to develop these new medicines that can, literally save people's lives. And I know many people who are walking around today because of some investor was willing to take a risk, hopefully to make a big profit someday, to develop a medicine to help people. So no, I don't know where a quote like that would have come from. There's a lot of misquotes that go on. The 50 million position, the number I've heard is somewhere between 40 and 45 million. By the way, illegal people who are not in the country, who are not documented, this bill is very specific. They will not be entitled to federal benefits under this bill. And so there will remain people who are physically in the United States under this bill who are not entitled to insurance, and those are people who are not legally in the United States. That's why the number that's been estimated for coverage is about 97, 98%, rather than truly universal coverage. And I think there's broad consensus that people are not willing to support that care for illegal folks in the country. As far as the issue about taking over, the best estimates we have seen, if we do a public option, and I am a strong supporter of a robust public option, because it gives people a choice. Now, the Congressional Budget Office is a nonpartisan group. It doesn't work for the Republicans or the Democrats or the President. It's a neutral referee with a striped shirt and a whistle. And they have analyzed this proposal, and they've concluded that about 5 to 7% in the first decade or two, they estimate people would choose to go on a public option. I don't think that's a takeover of the entire medical situation of the United States, but those people will have been afforded an opportunity to get the kind of coverage that members of Congress have. So I hope that answers your three important questions. Now we have Patsy from Bainbridge Island.
From Bainbridge Island.
Yes.
And thank you, neighbor, for doing this. And incidentally, I think that our nonprofit...
Is this Patsy Cook?
Oh, say again?
Is this Patsy Cook?
No, this is Patsy Campbell.
Oh, Patsy Campbell. Excuse me.
Okay. And I think our nonprofit HMO group health is wonderful. My question is there anything in your bill, Jay, that has some patient responsibility? My point being, if somebody is obese and has gone through treatment and care and continues to overeat and not exercise, is there anything in the bill that can say, okay, you can't be treated any longer? And or if a patient has been treated for instance, lung cancer, and has had good care and so forth, but they continue to smoke, can the health care person say, that's it, you don't get any more care? My point being there has to be some responsibility of the patient.
Well, there's nothing that that is, clear in that regard. There's nothing that would say that the people in that condition would lose their health care coverage. But what there are a number of provisions that would allow health care plans to provide wellness and would allow them to develop systems like that. For instance, Safeway and REI, the CEOs of those two companies, were just back at the White House a couple weeks ago talking about a program they have where they give incentives rather than a stick. They give carrots to people, which basically gives them bonuses on their pay or additional benefits on their health care coverage if they do follow some healthy living styles to try to keep their weight under control and their blood pressure under control. So they're using some carrots, and they have had tremendous success keeping their medical inflation down rate. Safeway and REI think that they haven't had any medical inflation last year or two because of these wellness programs working with their employees. So I think carrots work better than sticks in these circumstances, and this bill does allow, in a variety of contexts, carriers and employers and physicians groups to work with their patients to try to work towards those healthy living. And we know, as one of the other callers talked about, the nutritional therapist, that's absolutely pivotal. It's just so much more effective to prevent someone from developing diabetes rather than have to deal with the horrendous consequences of it if you don't. So I think the bill does take the right approach on this, and more Americans are starting to enjoy the fruits of, walking a little bit and not smoking. And I think it's the right direction for the country. We are approaching the end of our discussion. Let me ask my staff. That's about time up. Okay, we are going to now have to conclude with people's comments. I'm going to just make a couple closing comments. First off, I want to thank everybody on this call. You are part of trying to fashion what we're going to do in Congress, and I've learned a couple things tonight listening to you. And I'm going to put some of your ideas to work, and I hope the bill will improve to incorporate some of the ideas we've talked about tonight. And I hope that there's a product that can reach broad consensus. I don't know the answer to that yet, whether that will succeed, but I think that this discussion needs to continue. So I do want to thank you. I also want to make sure that people who did not get their questions answered tonight, we had 9,000 people on this call tonight, so we had a very large neighborhood meeting, so we couldn't get to everybody's questions. But if you have a question you'd like me to answer, if you can send me an email, I will be happy to answer it. You can send an email to Inslee, Jay.Inslee, that's J.Inslee, at mail.house.gov, at mail.house.gov, and we'll get an answer to you. Or you can call us at 1-800-226-7144, 800-226-7144. You can also sign up for updates. We send out updates now and then at my website, which is www.house.gov/Inslee. That's .house.gov/Inslee. And as always, we're looking for your comments and questions, so I hope you will give me those ideas. I've got to now sign off. We've run out of our contract time with a great phone company. I will look forward to this discussion with you. I hope you'll continue to think of it a continuing dialogue. And thanks for your help on tackling this. I hope we can help America improve. And good night all. Take care.